Important.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Anita Asif, and I am here to present you the topic CTG, that is also known as cardiac topography. It is defined as continuous graphical tracing of fetal heart activity as well as uterine contraction, both in the same time scale through uterine fuses and contractions. We can see in this diagram, these two probes are placed on abdomen of a female to record the fetal cardiac activity. This one uh, it records the fetal cardiac activity, and the second one above records the contraction. There are two types of CTGs that are present. One is internal and other is external. Mostly we use external CTG. The internal CTG was previously used in which the probe was attached to fetal head to monitor the cardiac activity. And the next one, which we commonly use in labor room, as I previously defined, that one probe is placed on fetal heart and second on the fundus to monitor the uterine contraction. There are various factors that affect the fetal heart rate. These factors include maternal, fetoplacental, fetal, and exogenous. Maternal factors further include the physical activity, posture, uterine activity, body, and the fluctuation blood pressure. The fetoplacental factors include age of gestation, umbilical cord compression, placental insufficiency, and chorioamniotis. Fetal factors include movement, fetal behavior changes, stimulation to wake the fetus, and hypoxemia. And exogenous include noise, medication, smoking, and drugs. This is the method we usually do CTG in labor room. There are few features that define a CTG. These features include baseline variability, accelerations, and decelerations. Baseline heart rate, basically the baseline heart rate of a normal CTG range from 110 to 160 beats per minute, and it's determined over 5 to 10 minutes. If the rate increases above 160 beats per minute, it is known as fetal tachycardia, and if it decreases 110, it's called fetal bradycardia. This diagram shows the baseline of fetal hearts, and it's monitor this one. It's the baseline cardiac activity of a fetal heart. There are various causes that causes tachycardia include maternal fever, chorioamniotis, fetal sepsis, drugs, fetal hypoxemia, tachyarrhythmias, fetal heart rate failure, etc. This CTG shows fetal tachycardia. The fetal heart rate is about 160, it's around 180 beats per minute. And this CTG shows fetal bradycardia, it's below 110, it's around 80 beats per minute and then 60 beats per minute. Baseline variability. Interval between successive heartbeats is called baseline variability. Fluctuation in the baseline heart rate that are irregular in amplitude and frequency calculated as amplitude of peak to trough in beat per minute. Here are this is a CTG showing baseline variability in a CTG. There are various factors that cause abnormal variability that include fetal sleep, hypoxia, fetal infection, drugs that causes suppression of fetal CNS. In this CTG, we can see there is no variability, just a baseline heart rate is present.
No. Just 1 second. Why do you think the baseline variability? Why do you think the baseline variability is important? The variability is important. Just to go back, if everybody. Anyone? What sort of branches of the nervous system was it called?
Where are autonomic nervous system?
Autonomic nervous. the activity of the sympathetic and the parasympathetic autonomic nervous system. So in actuality, what it represents is that if it's not variability, either it's not too high or it's not a flat line. So what it reflects is that the baby's brain or the CNS, central nervous system of the baby, is getting adequate oxygen. Therefore, there is highly unlikely that there will be hypoxia. So that's the game. So carry on. Well done.
Then the next feature is fetal heart rate accelerations. Increase in baseline fetal heart rate of at least 15 beats per minute for 15 seconds. 2 or more acceleration in 20 to 30 minutes is called reactive CTG and is non-hypoxic fetus. These are accelerations that are shown in CTG.
What is the prolonged acceleration? Over 2 minutes, but less than 10 minutes. And if it is within 10 minutes, what is it called? Then when you take it to baseline. Could you request them to meet? Pretty good stuff. All I'm trying to tell you is that if the acceleration lasts for more than 10 minutes, but more than 10 minutes, then it's a change in baseline. ठीक है, वो जो आपने पहले बताया ना ब्रेडिकार्डिया वाला, उस पर जरा जाओ आप. I apologize for speaking in desi language. Is it 10 minutes? Count the dabba. So you would term it as that same thing happens with the bradycardia. If it's more than 2 minutes, less than 10 minutes, that's called a prolonged decel. If it's more than 10 minutes, then the baseline is shifted. Then you better do something to become, it's down for out. So that's important to realize. Acceleration done. Yes, Mr. Patel. What do you think causes an acceleration?
Nutrient consumption.
Chalo, fair.
Fetal movement.
Well done, fair. And then what happens? Catecholamine is released. It stimulates the ANS. ANS के दो parts होते हैं. का क्या बताया था?
Sympathetic and parasympathetic.
हाँ, sympathetic, parasympathetic. Sympathetic वाला क्या करता है?
High.
ज़्यादा. ठीक है. Vasoconstriction. Or whenever sympathetic system is involved, it starts causing a brain sparing effect. What was that? What was the brain sparing effect?
Blood supply was shifted to vital organ like brain.
If it was Pakistan, the blood supply would have shifted to the limbs. The brain would have been allowed to go on. So the brain is kept by nature. Okay? And in actual fact, then what happens? अगर इसी तरह कोई भी बच्चा is subjected to short but consistent periods of hypoxia and decreased oxygenation, even though they are not in labor. What long term? What happens to the baby then after 4 weeks, 6 weeks? The baby is still alive.
The
IUGM. Brain sparing effect. The head is growing,
but the body,
particularly one measurement we spoke about,
abdominal
circumference. So the abdominal circumference, why? We spoke about that also. Why is the abdominal circumference less than? Logical path. Tell me. What lies the abdominal circumference is primarily the liver, no?
Yes.
What? Glycogen. There is a deposit of glycogen which is used when the baby is that is used as anaerobic respiration. That's your energy. That's the fuel. So, उसको convert करके वो you've read biochemistry.
Yes, sir.
वो सारी साइकिलें जो थी, ठीक है। So that is used by a chronically hypoxic या baby who is small. The BPD is fine, the
But
head circumference is fine, but the abdominal circumference measured at least 2 to 4 weeks, 3 weeks less
less
than
than.
the BPD. You should be alerted that this baby could cause you a problem whenever labor starts. So, well done. Let's go.
So next is fetal heart rate decelerations. Transient decrease in fetal heart rate of 15 beats per minute or more for at least 15 seconds, indicative of fetal hypoxia or cord compression. As I already told, if that lasts for more than 10 minutes, it will shift to Brady.
It will shift to more than 10
10
minutes
minutes
is a
baseline.
change in baseline.
Baseline.
2 to 10 minutes is a prolonged ready.
Right.
More than 2 minutes is prolonged. T-cell हो गई, ready हो गई, whatever you call it.
But after 10 minutes, it will
You just tell them that the baseline has shifted.
shift. Now, sir, CTG fetal heart rate decelerations are early, late, and variable. They are classified in three. The early decels are uniform shape, lowest point of same time of peak contraction. These green ones show the early decels. The late decels are uniform shape but gradually change, lowest point after peak of contraction. Then variable is commonly seen. These are variable in shape, duration, and intensity, not constant with the peak of contraction.
Sure.
These ones.
Well, they're not associated with the contraction at all. It can happen anytime.
Anytime.
So in early, why do you think it happened? I just want you to remember 2 to 3 words about whatever is going on. So, cord compression. Take it. Next, head compression. Descent of the head can cause an early decel. That is the hypothesis. That is, I'm not saying that this was written in the Quran or something. This is the hypothesis. This is what they think happens. They can be wrong. ठीक है जी? Next पे जो वो जो नहीं वो वाली बड़ी अच्छी है तुम्हारी slide. Well done. It's a good slide. Actually, I was trying to find it, but then I'm very bad. Okay. Late deceleration.
So these purple colors show the late deceleration. They are not lowest point. Blue one, yes, blue one at the end of uterine contraction.
ठीक है. Basically है कि it can basically happen while it is associated with the contraction. If you notice the peak of the contraction with your dotted line, and if you observe the blue line on top of it, the decel starts at the peak of the contraction. Okay? And it goes down after the peak of the contraction is gone. Okay? And it goes up afterwards. That's why it's a decel. And it's not a change in the baseline. Okay? And so it is related to the contraction. Early, it starts happening, the peak of the contraction coincides with the drop of the lowest point of the that thing, the deceleration. Okay? So in that case, the baby is tolerating it well, and it's probably not affecting, there's no consequence of hypoxia. If you start to just put a puta whenever this happens in real life and just see what do you think. So you'll get more confident at it, then you actually start making better decisions, or hopefully it helps. Why does this happen? This happens. Compression होगी ना? It's related to a contraction. So there is ठीक है. Oxygen कम होगी तो pelvis में. What will happen? Partial pressure of oxygen will reduce.
सर आपकी आवाज बहुत कम आ रही है.
ठीक. हाँ. अच्छा. अब आवाज आ रही है जी? हेलो.
सर पहले से बेहतर है.
Thank you. क्या होता है in late decelerations, uterus contracts, the blood vessels of this the blood vessels which are inside the uterus traverse the uterus and go inside, which is the placental thing. They also contract. They contract. That means that blood oxygen carrying capacity of these blood vessels is limited. तो pelvis के अंदर blood कम जाएगा. Partial pressure of oxygen होगा, वो कम होगा. अब this straight away will not have an effect on the baby. If this continues, ठीक है, अगर आप इस सिम्टो लगा के भूल गए या ज्यादातर होता है, if you're not properly monitoring it, if you have stepped up syntocin onto जितना भी drops, and then it starts to slowly start affecting the baby. Initially, it will have a buffer, it will have a mechanism to auto-correct itself. But then if you repeatedly cause this to happen, yeah, if the baby is chronically already hypoxic, the baby is IUGR, okay, then you will have more chance. So the partial pressure of oxygen is reduced. That in turn causes koi bala kaam. The sympathetic response of the autonomic system is autonomic nervous system is activated. Sympathetic response hogi. Kya hoga? There. Vasoconstriction mazid hoga. Blood will shift towards the brain, away from the limbs. When this sort of thing happens, how do you know a chronic hypoxic woman? What will she tell you when she comes to the labor ward? What complaint will she have? Good, think about it.
Decreased
Decreased
fetal
fetal
movement.
Fetal movements.
Ah,
Decreased
well,
fetal movements.
excellent. Well done, Siglan. So that is the thing. So correlate these things so that to understand what's going on. So if somebody says decreased fetal movements, never dismiss it out of hand. Have a good look at what is going on. Yes. You're raising the hand with okay. Someone suffered. करे क्वेश्चन जी म्यूट तो नहीं किया हुआ है
नहीं सर
लेकिन क्या तो कर and when that thing happens, then obviously Alamia wants to create a balance. The parasympathetic is initiated and it will have the exact opposite effect. If the baby is not hypoxic, if the baby is reasonably healthy before this whole thing starts, the baby will still deliver normally and you will have a first class thing. But if the baby is already compromised, or if you panic as a doctor, you'll end up doing a C-section. Or at least an instrument delivery. Right. And now come to the variables. Variables are the one in the purple, na?
Yes, sir.
What do you think? They have any sort of relationship with these pains or contractions?
No, sir.
Okay. So it's an abrupt decrease in the fetal heart. That does not mean it's not pathological. Why do you think they happen? Uphold your cord compression. sympathetic response, a little bit of tachy, then further cord compression happened for whatever reason, we don't know. And then the arteries got involved, and then the parasympathetic kicked in, and then there is a big dip. And as soon as there is a little bit of cord compression was relieved, maybe by changing the posture, maybe by doing whatever, okay, then the thing starts to baseline and then recover slowly eventually, because the exact opposite happens then. So when the parasympathetic takes over, then the sympathetic is trying to get in there and trying to create a balance, which is what is needed for living. Okay? These are variables. These, the variables and the lates are the ones to remember because they are pathological. The early D cells can be physiological because the baby is doing well. You don't need to act. You just need to make sure it doesn't happen. Okay? Continue, madam. Thank you. Sorry, Tirthankar.
Okay. So next are the features of CTG.
Ji.
CTG can be reassuring, non-reassuring, and abnormal. This can be seen through the baseline variability, deceleration, and expression that are present on CTG. If the CTG is reassuring, the baseline heart rate would be 110 to 160 beat per minute within the range. The variability will be less than equal to 5. Deceleration will be none. Acceleration present, absent. Otherwise, CTG is uncertain, significant.
Okay.
Non-reassuring, the heart rate can be less than 100 or more than 160, and variability more than 5 for less than equal to 40, but more than 90 minutes. And deceleration, early, variable, single, prolonged for up to 3 minutes. Then abnormal CTG, heart rate would be less than 100 or more than 180. Variability will be more than 5 or 90 minutes, and atypical late single prolonged for 3 minutes. Decelerations.
All right. You also mentioned there's this last pattern called sinusoidal.
Yes, sir.
Okay. So sinusoidal reflects what? What sort of pattern is sinusoidal? Sine is it's a wave. It's like this. There's no baseline. There is nothing. It reflects the fetal anemia. Is there any test which we can do for fetal anemia besides that the wave that we see? Forget the CTG for a second. Any other fetal blood anemia?
Anemia
नहीं यार. कोई non-invasive test है which you can see the signs of fetal anemia, which is the single most probably ultrasound पे किस चीज का देखते हैं check for fetal anemia? Middle cerebral. ठीक है? So remember that one. Fetal anemia and middle cerebral artery का कोई देखते हैं ये लोग diastolic करते हैं उसका diastolic to find out whether there is fetal anemia. I've never done it. It's all theoretical. It may be asked in an MCQ. Okay, so that's what I've done. Thank you. Understand. The pattern of sinusoidal is, you said more than 10 minutes. I think it's close to 30. Chalo, that's variable manager. Purana padao. But the thing about sinusoidal pattern is the sinusoidal, you need to see it. अगर है किसी के पास तो वो देख ले sinusoidal को Google करके, क्योंकि it sits very straightforward, but it's very important also because it's the other problem with sinusoidal is, I mentioned it to you, baby can be sucking its thumb and creating a sinusoidal pattern. Okay, all right, that's also good, but half an hour is fine, okay? Particularly in late labor. All right. Now it's suspicion. What will you do? Koi man.
Yes, sir.
Somebody write that down. We are going to chipify it on the labor.
Sir,
1,
left,
2, 3, 4, 5, 6. सारे consensus बना. क्या करूँ?
sir, left lateral,
क्या हुआ?
oxygen.
क्या हुआ? देखियो, ठीक है, fluids,
Yes, sir.
IV fluids. देखिए,
Synto, stop.
stop,
It's going on.
और
Sir, we will,
सीधा RM को चीज रह तो नहीं गए? मैं खुद पूछ रहा हूँ, मैं पढ़ के नहीं आया. I'm just asking you, to all of you sitting here, you guys are there in the labor ward. So let's make this 5, 6, 7 things what we need to do before doing an invasive thing, which is doing an ARM or putting your, doing a PV. Is there anything else left? We've put it on left lateral.
lateral.
Some people put up oxygen also.
Yes, sir. Oxygen, we do the same.
Then you basically left lateral हो गया, ये हो गया.
Sir, we will,
कैसे पता चलेगा?
सर BSR से कर लेंगे. सर maternal temperature.
तो फील हो रहा है.
टेम्परेचर देख लेंगे. टेम्परेचर maternal टेम्परेचर भी देख लेंगे.
टेम्प देखो, ठीक है, टेम्प ठीक है, कोई भी बात. तो मुझे 1, 2, 3, 4 करके बताओ steps, which seems logical and seems decent enough to be put on a wall. ठीक है.
सर स्टार्ट कर रहे हैं. फ्रॉम हेड टू वाइटल्स, मैटरनल वाइटल्स, इसमें ब्लड प्रेशर और टेम्परेचर आ जाएगा. मैटरनल पल्स रेट आ जाएगा. देन पेशेंट को लेफ्ट लैटरल करेंगे, ऑक्सीजन अटैच करेंगे, फ्लूइड्स देंगे, फीटल हार्ट रेट मॉनिटरिंग करेंगे कंटिन्यूस. सेंटो ऑफ करवा देंगे.
अब आओ नीचे. अब नीचे क्या करोगे?
सर पेल्विक एग्जामिनेशन
करेंगे.
सर आपने बताया था थोड़ा हेड पुश बैक करेंगे अगर कंप्रेशन की वजह से डीसल्स आ रहे होंगे.
If you can do an ARM, I think you should do an ARM, but I don't know because it's a private hospital. Maybe they'll like it, maybe they won't like it. I don't know. Do they do an ARM?
Yes, sir.
Oh, no, thank God. Then do an ARM. Okay. And while you're doing an ARM, while somebody looks at the monitor, trace it. For how many minutes?
5 to 10 minutes.
TV का नो यार. हाँ. 30 seconds. 25 to 30 seconds. Rub your fingers against the scalp of the baby after you've done ARM. नहीं, trace तो बेटे वो. What will happen as soon as you do that for 25 to 30 seconds?
So it will revert.
Acceleration आनी चाहिए. अगर acceleration नहीं आती, call the guy whoever is covering and tell him कि as in whatever, deliver the baby because the baby is hypoxic. अगर hypoxemia नहीं ठीक होता, and don't do PV, touch the baby's head, do this for 2 seconds and then come back. Do it for 20 seconds, 25 to 30 seconds, and tell the patient it's going to be uncomfortable. And chalo, you've done that, and she's like 9 centimeters. Congratulations. What do you do then? You'll obviously monitor the baby. Okay. How long is this thing valid for? This thing that you have done the scalp thingy, and now how long is this valid for? वो तो
15 to 30 minutes.
आधा घंटा. ठीक है, give yourself half an hour, and half an hour. Well, if you have to do it again and again, she'll end up killing you. But still, this is what you're supposed to do. Even when you're doing fetal blood sampling, and the pH is somewhere in between. Obviously, an acidic pH is less than 7.2. So if it's somewhere in between, then you need to repeat it after half an hour. Till the time that either you deliver, या फिर, it falls below 7.2 and then you have to do a C-section. So everything has a limited value because as they say, digital examination of a patient when she's in labor is basically remember this line and use it when you're teaching somebody else. It sounds very cool. It's a static assessment of a dynamic process. So at that time, you are basically checking her out at that minute. But after half an hour, things might have changed completely. So, and how do you do fetal blood sample? Has anybody ever seen a video? It's not the easiest thing to do.
So someone just told us.
It's quite intimidating to do at that time, particularly when the woman has not had an epidural. Even with an epidural, you are basically putting small sort of probe-like thing or something. Plastic there is this. You put it inside the vagina. You then then you're looking, then somebody places the light behind you, and then you see inside, and then you actually see the cervix, this dilated, and from in between you see the baby's head. So if she's 3 to 4 centimeters dilated, you will get this much of the baby's head.
So like we do PS examination with Costco's, it's like that.
It's worse than that because the cylinder is quite long. So it's like this plastic cylinder which you put in, like a tube, large tube, where your 2 fingers and your instrument goes in with your hand. So you clean the head with the sponge which you have, which you're holding with the sponge holding forceps. You clean it, then you see it, and then by that time that woman is like almost killing you. So there's somebody holding her leg. Either she is in left lateral or she is in lithotomy. Usually they're not in lithotomy because they're in first stage. So it's quite difficult and your back is killing you at the same time. Then they give you a spray. Then you spray that thing on the baby's head from a distance because the tube is like this. So you're spraying it on the baby's head. This causes congestion in the baby's immediate scalp area. And then and then they give you a knife. So the knife goes in and you just stab the baby's head. It's a very small thing. By that time you want to kill the baby because you're so tired. So you stab the baby's scalp, and then they give you a pipette, 2 pipettes actually, long glass pipettes, which you are supposed to very expertly or gently place where the scar is, where you stab the baby, and that blood trickles down in the pipette for a good distance. Okay. And there is not supposed to be a drop of air in the thing because if you move your hand, then air might come in. So you take one sample, and then she makes you take another one because the midwife is standing on your head. So you take 2 samples, then she immediately does a pH, and then she comes back and says, the Dr. Khan, the samples were useless because they were there, and then the process starts again.
So why can't we use cross-spots? Why that long tube and make it more heatless? Why can't we
Because you need better visibility and you need a thing which actually stays inside for a while because it's not a small thing to do. The cusp, she'll move, she'll immediately it will go outside. So the more dilated she is, the easier it is to do. But people are forced to do such thing or were forced to do such thing at 3 centimeters, which was quite nerve-wracking. So I think that's why they are slowly shifting away from this nonsense now. And this scalp thing, 25 seconds is the best thing to do. Well done. आगे चलो. Biophysical profile. लिख लिया है किसी ने? हैं? अब इसका मुझे कब दोगे तुम लोग? इसको बस टाइप करके एंड इसको कोई थोड़ा बड़ा करा के ये इसको हमने बस चिपकाना है दोबारा. This is what you're supposed to do, and then call the consultant. Okay? And make sure that FZ and RS have a look at it. Good, So,
The CTG is also helpful while doing biophysical profile. Biophysical profile is a way to check overall fetal health. It consists of two painless, non-invasive tests. One is fetal monitoring and ultrasound. The fetal monitoring is done through CTG. Long 30-minute CTG is done through ultrasound machine to look at fetal behavior, CTG and amniotic fluid volume, and scores are given accordingly.
Okay.
And this said, the higher the score, the more it is known.
Why do you think what is the modified biophysical profile? See, AFI क्यों important?
Like the baby cut. It should be adequate.
ठीक है, कितना होता है?
एज के gestation age के according नहीं होता है. Late gestation में around 10 is normal. Term के around adequate. 10.
कितने से कम नहीं होता?
9 seconds.
6 to 7.
7.
कोई और नंबर आएगा क्या? मेरे ख्याल में 5 है. ठीक है. AFI का मतलब क्या होता है?
Amniotic fluid index.
How do you calculate that?
It's a 4
4 deepest vertical pools को आप लेते हैं. You add them up, and then it should be more than 5. ठीक है. सिंगल डीप वर्टिकल पूल का भी एक बेनिफिट है कि वो भी आप ले लो तो वो भी मेरा ख्याल है 2 सेंटीमीटर से ज्यादा हो या इस तरह का. But what I want you to do is modified biophysical profile has proven to be almost, if not more effective than the normal biophysical profile which you send the patients downstairs for. ठीक? Because every time अगर आपने central localization देखनी है या UGR देखना है तो चलो ठीक है आपने करा लिया. लेकिन fetal well-being के लिए you can use a modified biophysical profile. You can put a probe there, do your AFI thingy or your deepest vertical pool right there, and correlate it with the CTG. If the CTG is reactive and you have about 3 or 4 or 5 centimeters vertical pool, deepest vertical pool, it will take you 5 minutes and you can send the patient home or whatever. Okay? Amniotic fluid index, why is it important? Again, the same question. Where does the amniotic fluid come from? किसकी?
Fetus.
Why? How? Why is it important again? What is the brain spraining effect? What is the brain sparing effect which
Where
was just
Where the
speaking?
blood is being diverted to the brain and like white body.
Yes. So if the blood is consistently, there is a chronic insult, yeah, PIH, yeah, diabetes, or whatever she has. So the baby's brain is being protected over a period of months. This will slowly result in the kidneys being supplied with less blood, hence less urine production, hence AFI decrease. What are the other causes, important causes of when you do a scan, you see the liquor is not there? What is the most important thing to consider? Leaking, the gland. Okay? Once you've ruled out leaking, the other thing you need to understand is AFI can come out. And as you approach term, it goes down. And by the time a woman is 42 weeks, okay, 2 weeks over, the the amniotic fluid thing or whatever AFI or whatever fluid around the baby you call it, more than 50% or at least 50% of that is meconium. Okay? So that's called post-date pregnancy, 42 weeks से आगे. So that is why the RCOG people or whoever the hell they are, they started to induce women at 41 plus 3.
But sir, here in Pakistan, 39 weeks to 40 weeks is the maximum limit.
It's
मैडम और फिर करते हैं मैडम के 40
40 तक जाता है, not above 40.
ये we at services hospital used to induce them at term plus 10 under exactly these same things. Okay? But at that stage, you guys know a lot more than I do. At that stage, I had no idea what I was doing. I was just doing. Okay? So what I'm trying to make you understand is, if you can understand why you're doing things, that makes your job a lot easier. Okay? So I was just doing. So I'm just trying to. I'm not focusing on but just to make you understand why that is happening. Okay? So term plus 10 is that is the reason for the amniotic fluid, because the baby becomes mature, and after maturity, the first thing the baby does is pass meconium. Okay? And if the baby is passing meconium before 39 weeks, then there is some problem. Okay?
Stress.
फिर कुछ हो रहा है. And what is the most common thing to rule out? What causes the babies? What is the pathological condition, medical condition associated with passage of meconium in a baby? Most common, seclair. Well done. Okay, that's how you remember things. That's how at least I remember things. Okay, okay. Well done, Anika. And Anika will make that thing. Congratulations, beta. Well done. अच्छा अब अगर okay, fine. Tell me what next. If we decide to
Sir,
do
is
it,
speed sharing now, stop political bit of after that.
नहीं sir, नहीं है, पाकिस्तान से
तो 5 मिनट
है, क्लास में नहीं है ना,
तो देखना आ सकते हैं.
ये मुझे
कल
कंफर्म
ग्रुप में अपडेट.
either Australia.
यस, मेरा व्हाट्सएप लॉग आउट कर, स्क्रीन शेयरिंग बंद कर दिया.
अच्छा मुझे बताओ पढ़ने क्या मिल रहा है उसमें आगे लिखना.
डॉक्टर सुनीला
ब्लैक आर्टिकल नहीं पता, पॉड के अंदर लिखनी